Hello. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for part 3 of this 3-part CMEO briefcase series titled, What Should They Expect? Making time to talk to patients about pain before their dental procedure. Today's case is focused on patient education, a very important part of helping patients understand not only their procedure, but what to expect related to pain afterwards. I'm Mona Saragi. I'm a dentist anesthesiologist and diplomate of the American Dental Board of Anesthesiology. I'm the director of the Dental Anesthesiology Residency Program at Jacobi Medical Center and an assistant professor of dentistry at the Albert Einstein College of Medicine in the Bronx, New York. Our learning objective is to educate patients about their pain and non-opioid pain management to optimize safe and effective multimodal treatment plans. Let's meet Helen. Helen is a 63-year-old Hispanic female. She's scheduled for tooth extraction and immediate implant placement. When you bring up pain management, Helen is adamant about not using opioids. She says she doesn't want opioids around the house because of the kids. Upon further discussion, Helen shares that she has a family member in recovery and is worried about them having access to opioids. What would be your approach to pain management for Helen? Let's ask ourselves, do all surgical procedures require opioids? In a study of 190 patients undergoing 6 procedures, they were offered the opportunity to participate in opioid-sparing management. They were advised to use acetaminophen and ibuprofen and were given a small rescue opioid for severe breakthrough pain. 52% of patients used no opioids at all. Patients also reported a high degree of satisfaction in pain control, and 91% said that their pain was tolerable and manageable. This demonstrates that we can reduce or perhaps eliminate opioids after minor surgical procedures and that this is an effective and acceptable way in treating patients' pain. How long is the course of odontogenic pain? Most sources will say 3 to 5 days at the most. So the pain is driven by inflammation and inflammatory mediators, including things like prostaglandins. Pain peaks at 8 to 12 hours after extraction, and extraction pain rarely persists beyond 2 days after surgery. 53% of patients actually reported a low pain score even on the first day after surgery, and by postoperative day 5, 80% reported minimal pain. So you can see that even on postoperative day 1, there may be a small group of patients who need opioids in addition to their NSAIDs and acetaminophen. And unfortunately, it's hard to predict who will be in that subset of patients. Pre-operative patient education is so critical to reducing opioid use. Written, oral, and visual patient education have been shown to minimize the use of opioid analgesics after surgery. In fact, in one study, 90% of patients who got pre-operative education declined the opioid prescription and didn't ask for opioids later on during the postoperative period. Conversely, 100% or all the patients who didn't get education filled their prescription. What does that tell us? It tells us that when patients know what to expect and not just that there may be some pain, but that they're instructed in the quality of the pain and are reassured that it's a normal part of the healing process, then they will feel safer and be less likely to take meds. So let's discuss some strategies for managing expectations. Managing expectations is key not just for postoperative pain, but for the doctor-patient relationship in general. Patients should understand that the pain, or rather some discomfort, is to be expected as part of the healing process, and educating patients about this is essential. Patients should have the right expectations. Is a little dull ache to be expected after having a surgical procedure that involves the destruction of both hard and soft tissue? Probably yes. But simply telling the patients you won't have any pain at all is a disservice, because when the local anesthetic wears off, the patient will wonder if something is wrong because they were not told to expect any discomfort whatsoever. You also want to educate the patient about the time course, that the first 2 or 3 days are the worst, and that by day 5, the pain should be almost resolved, and to come back and to see the provider if the pain lingers. Patients should be given information about what they can do to feel better. The frontline drug should be NSAIDs, layered on with acetaminophen for severe pain, and the opioid should be reserved as a supplement for the most severe breakthrough pain. Non-pharmacologic techniques are effective as well. This includes the use of ice, which also helps with swelling, as well as practicing relaxation, mindfulness, and aromatherapy as adjuncts. And these adjuncts are non-pharmacologic and therefore do not have the same side effects as our analgesic meds. Make sure to engage with patients in the pain management strategy as part of shared decision-making. First, take the patient's medical history carefully and consider your findings and any contraindications or indications for a particular medication when prescribing. Next, you want to engage in adequate pre- and postoperative discussions about postoperative pain. You want to have an open discussion about expectations, reassuring the patient that they will be safe and comfortable. You need to discuss the risks and possible side effects of medications, including addiction and overdose. The last part is very important. We need to balance compassionate care that manages suffering with safety. Sometimes the cure is worse than the disease. And what I mean by that is sometimes telling the patient that they won't feel any pain and then giving them a large quantity of opioids is worse than the postoperative pain itself. If the patient is adequately numb and has the appropriate non-opioid medications, prescribing a small quantity of opioids for severe breakthrough pain may be the best course of action, and the patient should know that there might be some discomfort or some swelling rather than being told that there would be no pain at all. Patients who know what to expect will tolerate a little discomfort better than somebody who's told that they won't feel anything at all. Patient satisfaction. So patients will be most satisfied when they feel that the provider shows empathy and compassion and that their concerns are being heard, that their pain is being acknowledged, and that their concerns are being addressed in a manner that prioritizes patient safety. Multimodal analgesia is a buzzword in the age of the opioid epidemic, but it is something that dentists have been doing for a long time. Multimodal analgesia, as its name implies, means that we are providing analgesia at multiple inputs on the pain pathways and therefore achieving synergistic analgesia by utilizing lower doses of medications from different drug classes, and this can reduce opioid requirements. What do we as dentists do for almost any procedure? We get the patient numb. So local anesthetics can act by blocking sodium channels and preventing the transmission of painful responses from the site of injury or surgery to the central nervous system. There are a few exceptions to this. There may be patients who have a true local anesthetic allergy and or the patient might be unconscious because they're under general anesthesia, but we absolutely need local for almost all procedures. Profound local anesthetics and long-acting local anesthetics, such as bupivacaine, can block the transmission of nociceptive inputs along A delta and C fibers to the central nervous system for hours postoperatively, and this will help reduce the pain. The A delta or C fibers are going to carry the pain signal to the central nervous system, and since they're the first neuron to go from the site of injury to the CNS, we call them primary afferents. The primary afferents enter the dorsal root ganglion as seen here and communicate or synapse with the secondary afferent neuron in the dorsal horn of the spinal cord. The primary afferent releases substance P. The secondary afferent then crosses to the other side of the spinal cord and synapses with third order and fourth order neurons, which can eventually sense or feel pain. NSAIDs act by blocking cyclooxygenase enzymes, which produce prostaglandins. The prostaglandins sensitize free nerve endings at the site of tissue injury or trauma or surgery. So by reducing the production of these prostaglandins, we reduce pain by interfering with the mechanism of action for the pain. Although the mechanism of action for acetaminophen is not fully understood, it's thought that acetaminophen is a weak inhibitor of COX-1 and COX-2. But unlike the NSAIDs, which block COX in the actual substrate binding channel, acetaminophen disrupts COX electron transfer. In other words, acetaminophen acts on COX, but in a way that's different from what we know about NSAIDs blocking the production of prostaglandins. Although the mechanism of action of acetaminophen is not fully understood, it is thought that acetaminophen is a weak inhibitor of COX-1 and COX-2. But unlike NSAIDs, which block the COX enzyme in the substrate binding channel, meaning they prevent the production of prostaglandins, acetaminophen works somewhere in the catalytic center by disrupting electron transfer. In other words, acetaminophen acts on COX, but in a way that's different. There are also proposed centrally acting mechanisms for acetaminophen as well. Acetaminophen has a different mechanism of action and therefore a different side effect profile. So acetaminophen will not cause bleeding, gastrointestinal upset, or renal dysfunction, but rather the main concern is liver toxicity. And therefore, we can add acetaminophen to ibuprofen for a synergistic analgesic effect. Lastly, we have opioids, and opioids act mostly centrally. So opioids are not going to interfere with the mechanism or cause of the pain, but rather they're going to reduce the awareness of pain centrally. They're also going to activate descending analgesic pathways, pathways that descend from the CNS down to the spinal cord and inhibit the release of substance P by the primary afferent neuron. And the side effects include nausea, vomiting, constipation, sedation, and respiratory depression. Another concept that you should be aware of is something called the NNT, or the numbers needed to treat. So the numbers needed to treat mean that you need to treat a certain number of people to see a certain effect in one person. And so for these pain medications, the numbers needed to treat is for one person to achieve 50% pain relief. The ideal numbers needed to treat, or NNT, is 1, because that means that everyone who gets treated achieves the desired effect. For oxycodone 15 milligrams, 4.6 people need to be treated for just one person to feel pain relief of 50%. So one person will experience at least 50% pain relief, and the other 3 or 4 people may still experience the unpleasant side effects, or potentially worse, be exposed to opioids and be that patient who is at risk for addiction. And for the ibuprofen 250 milligram and acetaminophen 500 milligram combination to the right, you can see that the NNT drops to 1.6, which is pretty close to the ideal NNT, which is 1. Here are the evidence-based recommendations for prescribing analgesics for acute pain in dentistry. To the left, we have a column that describes mild, moderate, and severe pain and includes examples of the typical procedures that produce such pain. So a simple extraction or routine endodontics, such as a root canal therapy, may result in moderate pain, while surgical extraction or quadrant periodontal surgery with flaps and bony recontouring may cause moderate pain. And severe pain may result from partial bony or full bony impaction surgeries. This is not a comprehensive list, but it's meant to be a guide. And certainly there may be individual variation on how each patient experiences pain. The treatment algorithm for patients who can tolerate NSAID therapy is in the center column. For mild pain, the regimen is ibuprofen 200 to 400 milligrams every 4 to 6 hours as needed for pain. Now, if the pain relief is inadequate, or if you're starting off with anticipated moderate pain, then you can prescribe ibuprofen 400 to 600 milligrams every 4 to 6 hours for 24 hours. So instruct the patient to take the meds around the clock for the first day, and then switch to ibuprofen 400 milligrams every 4 to 6 hours on an as needed for pain basis. Again, if your patient reports inadequate pain relief or you foresee moderate to severe pain, now we would add acetaminophen. So you would take ibuprofen 400 to 600 milligrams with acetaminophen 500 milligrams every 6 hours, and you would take this again around the clock for the first day, and then have ibuprofen 400 milligrams every 4 to 6 hours on an as needed for pain basis. For severe pain, you can have the patient take ibuprofen 400 to 600 milligrams every 6 hours around the clock for the first 2 days. You can also prescribe a combination of acetaminophen 650 milligrams and hydrocodone 10 milligrams and have the patient take that every 6 hours for the first 2 days. After the first 2 days, you can switch to ibuprofen 400 milligrams every 4 to 6 hours as needed for pain. Now, you might have some patients where NSAIDs are contraindicated, and we'll get into the contraindications in just a minute, but the regimen is slightly modified. So for mild pain, one would start off with acetaminophen 650 to 1000 milligrams every 6 hours as needed for pain. For moderate pain, it would be acetaminophen 650 with hydrocodone 10 milligrams every 6 hours around the clock for the first day, followed by acetaminophen 650 to 1000 milligrams every 6 hours, again, as needed for pain. And then for severe pain, patients would start on acetaminophen 650 milligrams with oxycodone 10 milligrams every 6 hours around the clock for the first 2 days, followed by acetaminophen 650 milligrams to 1000 milligrams every 6 hours as needed for pain. So some key points about dosing. Patients should be warned about acetaminophen. The maximum daily dose is 3000 milligrams. There's a risk for inadvertent or accidental acetaminophen overdose because acetaminophen is found in a lot of formulations. Patients may not realize that the Vicodin or Percocet they're taking has acetaminophen in it, or that the over-the-counter cold medications also have acetaminophen in it. There are opioid rescue formulations that contain ibuprofen as an alternative to acetaminophen opioid combination therapy. The maximum daily dose of ibuprofen is 2,400 milligrams. A long-acting local anesthetic can delay the onset and severity of postoperative pain, and this is especially true with bupivacaine. Either the regular or liposomal formulations will work just fine in reducing the barrage of nociceptive input, and this can reduce pain scores for days. For those of you who provide intravenous sedation or intravenous antibiotics perioperatively, consider giving a single dose of the steroid such as dexamethasone to limit inflammation. Steroids are anti-inflammatory and act by blocking phospholipase A2, which is the enzyme that liberates arachidonic acid upstream from the COX pathways. There are certain patients in which we must proceed with caution when prescribing NSAIDs. These are patients over the age of 65 years, patients with a history of gastrointestinal ulcers or bleeds, patients with cardiovascular or renal disease, and patients taking anticoagulants, since one of the side effects of NSAIDs is increased bleeding. Patients who are taking drugs with a narrow therapeutic window with respect to dosing, such as lithium, may also be a relative contraindication for NSAIDs because lithium is excreted by the kidneys unchanged, and a week of NSAID therapy can increase the blood levels of lithium. The potential for leftover pills from prescriptions is a real threat. These pills can end up in the hands of vulnerable individuals who may misuse, abuse, or divert the pills. Here we can see a number of opioids prescribed in green and the opioids consumed are in gray. And you can see that the bulk of patients were prescribed somewhere between 6 and 20 pills, and those are the tallest green bars, and that the bulk of the patients consumed 0 to 10 pills, as those are the tallest gray bars. So there's potential for a lot of leftover pills, meaning that we don't need to prescribe as many pills. It is key to follow up with patients postoperatively. This is especially true if an opioid has been prescribed. The total duration of opioid use is the strongest predictor of future misuse. So regardless of the modality, whether it's an office visit or a telehealth visit, the postoperative appointment is an excellent opportunity to continue to educate patients about the risks of excess pills and the appropriate handling of medications to minimize misuse and diversion. It is just as important to query patients regarding continued opioid use and opioid disposal as it is to use this opportunity to recognize a postoperative infection or complication. Patients need education on the appropriate handling of medications, including storage and disposal of unused meds. Meds should be kept in a lockbox or secure or private location so that other members of the household do not know that the opioids are in the house. There are medication take-back programs, and you can go to www.takebackmymeds.com for additional details. If a take-back program is not available, medications can be disposed of in household trash by being mixed with dirt, kitty litter, coffee grounds, and then sealed in a plastic bag. But be sure to remove the identifying information such as one's name and address on the prescription label before disposing. Drug deactivation pouches are also available commercially and can deactivate the medications, making them unusable to anyone who finds them in the trash. And despite concerns for water safety and aquatic life, the Food and Drug Administration endorses flushing of opioids in the toilet. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what I hope our audience will take from this presentation to apply to their practice. Seize opportunities to educate patients, providers, and the community about the safe use of opioids. Educate patients about the safe storage and disposal of unused medication, and partner with patients and the community to be a resource for health and wellness. Thank you for joining me today in part 3 of our 3-part CMEO BriefCase series. If you haven't watched CMEO BriefCases 1 and 2, I encourage you to check them out at www.cmeoutfitters.com. Please also visit the Dental and Oral Surgery Education Hub, where you'll find other dental CE and CME activities, as well as a broad range of resources for healthcare providers and patients. I hope that this case and the data I've presented today give you something to consider related to the risk assessment for opioid misuse and diversion. You can click this link to take the post-test and print your CE certificate immediately afterwards. Thanks again.